welcome you all. Today, in a special episode that is frequently asked question, our topic is high flow nasal cannula. We have a very special guest with me, Dr. Samiuddin Sheikh. He is senior specialist in pediatric intensive care, Royal Hospital, Ministry of Health, Sultanate of Oman. He also has exposure in very good centers, including Fortis Scott Heart Institute, New Delhi, and also in Great Ormond Street Hospital for Children, London, UK. Welcome, Sami. It's nice to have you today in this question answer session.
Thank you very much. Nice to be with you again.
Actually, what is the purpose of today's meeting? High flow nasal cannula, although it's a standard of care in critical care settings, but in Bangladesh, only few centers were using this before the appearance of this pandemic. And as the pandemic started, now people started realizing the need for high flow nasal cannula, and many centers procuring with a double price due to crisis. But as we were not using this previously, we started having problems and questions and troubleshootings, and we have little exposure in this country, so these questions remain unanswered. So I thought, as you are using this frequently and you have exposure in this high flow nasal cannula, so I thought let us discuss few questions with you so that people can get answer, and at least I also get those answers. My first question is, as we are actually now we are using in COVID patient, but what are the common uses other than this COVID? What are the common uses, especially in your center?
So as you rightly said, high flow nasal cannula is still a relatively new kind of respiratory support in the non-invasive ventilation, I would say, equipment. So last 10 years, it has evolved much. It has become very popular. And I think the reason for popularity is the ease of handling. It's simple and it's mobile, doesn't require a lot of structured support compared to the CPAP or BiPAP devices. And I think that's the reason it made it more popular. And the second reason is the patient comfort. So if you ask the patient, most of the even older patients, what you prefer, high flow nasal cannula versus BiPAP, CPAP, they would like to have high flow nasal cannula. So the patient comfort and the use of ease of use, that made this very popular. Having said that, if you look around and try to find out what is the evidence, scientific evidence of high flow nasal cannula, there are not any studies besides the bronchiolitis group that has been very often used in infants with bronchiolitis. In that situation, it has shown of some benefit compared to CPAP or simple nasal cannula oxygen. But then from there, it has become popular, and we almost start using in all kind of respiratory distress. So mild to moderate respiratory distress in children with some oxygen requirement, our first choice would be high flow nasal cannula. So it can be bronchiolitis, can be pneumonia, it can be heart failure, or it can be post-extubation patients. So these are the common indications in our setting. Having said that, one must remember, high flow nasal cannula is not for very sick children. It's those mild to moderate children who require some oxygen and who get benefit from some respiratory support.
So we should not go for this in poor conscious patient or comatose patient. We should not try this thing. What do you say?
Exactly. Exactly. So this is the non-invasive ventilation, and the contraindication for the non-invasive ventilation, which is like poor sensorium, comatose patient with respiration, to apply to high flow nasal cannula as well. And this is the patient, the support provided by high flow nasal cannula is not that much compared to BiPAP or other devices. So it's relatively weak, I would say, positive pressure ventilation when you start comparing with other kind of respiratory support using positive pressure ventilation. let me give it background. So in general, I got the babies in the emergency department, 6 months old, who got working a bit moderate respiratory distress, who's tachypneic to 60, who requires 2 liter nasal cannula oxygen to maintain more than 90% saturation. I would say this is the right candidate to use the high flow nasal cannula. But if he's someone who comes with severely distressed, is desaturating in the non-rebreathing mask, then probably high flow nasal cannula is not for that group of patients.
I think the answer is very clear. And then in that case, a related question actually, when you prefer higher support, you have given the answer partly actually. So do you prefer in some cases CPAP or other NIV support other than high flow nasal cannula, or you are giving high flow nasal cannula? At what point you will prefer to switch to non-invasive CPAP or BiPAP or endotracheal intubation?
Right. So this is very good questions and very practical. Also, it has financial implications like countries ours, including Bangladesh. So you had to open up high flow nasal cannula package, then probably single-use cannula. If your patient doesn't get better, then you had to open another package of the CPAP or BiPAP circuit. There's extra cost to the patient. So it makes a lot of sense to decide at the beginning, what shall I do? I'll start with the CPAP or I will start with the high flow nasal cannula. So what I would do any moderately distressed patients who I think is with significant lung pathology, who got significant gas exchange in problem in the blood gases, I would preferably start the non-invasive positive pressure ventilation in the form of CPAP or BiPAP. Someone who's mild to moderately distressed and doesn't require that much oxygen, then I'll use high flow nasal cannula. So once we're starting high flow nasal cannula, I want to make sure that within 1 or 2 hours, the patient should respond. And response I will measure in the form of decrease in the respiratory rate, decrease in the heart rate, decrease in work of breathing, decrease in the oxygen requirement. Generally, our practice is to start 2 liters per kilo per minute of high flow nasal cannula, and the starting FiO2 will be something 60%, 70%. But we should be able to come down quickly to the FiO2 requirement below 50% or 40% to maintain the saturation, acceptable saturation, which is for a non-cyanotic heart disease patient will be 93 and above. If you're not able to bring down the FiO2 requirement quickly within 1 hour, 2 hours period to below 50 or 40%, and I think at that point of time, I would change escalate support to BiPAP or or maybe consider intubation. So the requirement of oxygen is very important here.
So we should not wait for unlimited time with a wishful thinking that patient may improve. We should not wait for 1 or 2 hours more than that after high flow nasal cannula. If there is no significant improvement, we should switch to higher level of support.
Exactly. It's very important to make that decision.
Yes.
Because there's studies have shown that if you stay around longer period of NIV, thinking my patient will get better, using very high FiO2, then eventually outcome is poor for these patients once they get intubated. So making that judgment call within first 2 hours of use of high flow nasal cannula, or for that matter, any kind of non-invasive ventilation is very important. So 1 to 2 hours, you think your patient got better, FiO2 requirement 40%, yeah, is getting successful, I will continue. FiO2 requirement more than 50%, then for sure I'm not thinking, probably this patient needs escalation of support, I would start considering intubation.
So before we start, we must have a plan, what I am going to do after 1 or 2 hours. It's a very good answer actually. I think it is clear now. My next question is, do you ever use high flow nasal cannula intermittently, or it is always continuously?
So another very practical question. So most of the time we try, if you start high flow nasal cannula, we'll give it continuously. But there have been some patients who require this support for longer period of time. And these patients, we want them mobilized as well, out of the bed, take for the walk in the corridor. So in these situations, in our setting, it is not feasible to continue high flow nasal cannula because we don't have stand-alone devices. We still use wall-mounted source of oxygen and air to provide high flow. So during that short period of mobilization, we disconnect. Maybe we can say 15 to 30 minutes, and then connect back to high flow nasal cannula. So beside those breaks, some older patients, they want to eat or they want to drink something. We come down the floor because it's a bit uncomfortable.
Very uncomfortable, yeah.
Very high flow, and at the same time, drink and swallow or eat, and maybe a risk of aspiration, small baby.
Now question related to if there is any problem or troubleshoot. Say, I have a feeling like when patient is in high flow nasal cannula, some patient keeps their mouth open. So actually, does it work well if patient keeps his mouth open? And what are the other troubleshoot or difficulties we may face during high flow nasal cannula?
I think it's a good observation and the right question. So that if patient keeps mouth open, how much support he gets from high flow nasal cannula? It's just like CPAP. So that the high flow nasal cannula is a very weak form of CPAP, I would say. They generate roughly around 3 to 4 centimeters of water CPAP level if you're using 2 liters per kilo per minute. So, and then the main effects are from the humidification of the airway. The warm humidified air that washes out the dead space of nasopharyngeal area is, I think, is more is the one which makes difference rather than the CPAP or pressure you get from the high flow nasal cannula. So keeping mouth open might dissipate some pressure out, but still it gives advantage of giving the warm humidifier air and washes out their dead space, nasopharyngeal dead space. It does give some benefit. But having said, if your patients start desaturating, keeping mouth open using high flow nasal cannula, then probably that's not the right support to use in this group of patients. That means they are sicker patients. Their requirement of pressure is higher.
Any other troubleshoot we may face?
So yeah, so I think sometimes this troubleshooting, I would say, is very simple. I haven't faced much trouble using it. But some of the older patients, they don't like the gush of air coming into their nose. So we felt that if you connect them immediately 2 liters per kilo per minute, they become very much claustrophobic and they become anxious and they stop using it. So the increasing the flow slowly might make sense in that setting. The other technical troubleshooting where the frequent disconnection from the humidifier end of the tubing. So the temperature probe from the humidifier comes out and nobody notices it because there's no alarm in the high flow nasal cannula.
Yes, exactly.
So if your nurses or the doctors at the bedside not very cognizant of this, if they don't listen to that sound coming from the the nasal prong, and then they will miss that the circuit is disconnected from the patient. That's one common observation. Second is the improper fitting of cannula. Many times I noticed that half of them is out and patient is not getting enough flow, the one you had desired. So these are common things, the patient's discomfort, disconnection from the humidifier side, and improper fit of cannula. These are the common problems we have seen while using it.
A very good practical point actually is proper monitoring and very good nursing care is mandatory, because as you told that as no alarm is there, so patient may not get the benefit of high flow nasal cannula, and we are thinking that the patient is doing well. So my next question is how to win actually. If patient is patient is improving or patient is doing good, how long we can take to win? Oxygen fast or flow fast? Is there any protocol or any policy?
So I think there's not much evidence-based practice into this, but every hospital got their own protocols. And generally, it says that first thing you should win is the oxygen requirement for FiO2.
Right.
You should be able to bring down FiO2 something like the 35-30%. And your patient is reasonably stable on that FiO2, then you start weaning their flow. So our practice is if our patients are stable on FiO2 of 35% and at the flow of 2 liters per kilo per minute for 6 to 8 hours, we start weaning down the flow by 20%, 25% of peak flow every 6 to 8 hourly. For example, someone who's on 20 liters flow per minute will reduce to 15 liter after 6 to 8 hours of stability. And every 6 to 8 hours, we keep coming down 25% till we reach to the 0.5 liters per kilo. And at that point, we simply change it to standard nasal cannula oxygen.
And then next thing is actually nebulization. So as it is very high flow we are giving through nasal cannula, so nebulization, it should not work well if there is very high flow. So how to nebulize, or if a patient want to eat or drink at that time, what can we do?
Yeah, so that's a good question. So if patient requires bronchodilator nebulization, then in that case, usually we reduce the flow during the phase of nebulization because of the same observation you made, that very high flow nasal cannula might not allow the nebulizer flow to reach to the patient. So in that period, for short period of time, say for example 5 to 10 minutes, we reduce the flow to the half and then give the nebulizers. Having said that, most of patients who require this high flow nasal cannula, in my observation, they need not be on regular bronchodilators. They're bronchiolitis patients, lung collapse patients, and heart failure patients. They don't get any benefit from bronchodilators, although we keep on giving them in practice.
Yes, that's the thing. Okay, it's practical points. And is there any contraindication? We also already actually discussed if you told about the consciousness and very sick status. So any other contraindication?
So generally there is no big contraindication for high flow nasal cannula. It's just giving the nasal cannula oxygen, but a pretty much higher rate. So air leak syndrome, or the abdominal distension, these are possibly some relative contraindication we can think of. But having said that, we have used in these situations that high flow nasal cannula did not worsen any of these pathologies. But general say NIV is not recommended. NIV includes high flow nasal cannula if you got abdominal distension, abdominal pathology, or you got the air leak syndrome. So these are some relative contraindications I would think of.
That is actually one problem. Actually, I forgot to mention the abdominal distension. Some patients develop significant abdominal distension. That is also another issue. And also we face this problem in CPAP as well. Is there anything special to do with this problem, abdominal distension?
So yeah, it's commonly seen in small babies actually, the abdominal distension, because of CPAP and high flow nasal cannula. And our practice is to keep nasogastric tube in situ as long as there are NIV in the smaller babies. And we'll make sure we give the NGT or nasogastric feeds, and we don't allow them to take oral feeds. And keeping NGT open might help to reduce abdominal distension.
We already covered all the questions, and it was very good interaction and nice answer actually given by you. All practical problem. I hope people will get benefit. And do you have any final remarks regarding high flow nasal cannula?
I think so. High flow nasal cannula is, as I mentioned earlier, it's ease and mobility. It made it very popular. But if you had to, because of financial constraint, if you had to make decision, my patient will go on high flow nasal cannula or CPAP, then I would err on the side of using CPAP, because CPAP is more effective mode of treatment compared to high flow nasal cannula, although both of them got their advantages and disadvantages. The financial constraints make them using more CPAP than high flow nasal cannula. Having said that, because of most of the companies which make high flow nasal cannula, they require their own specific nasal cannula, specific circuit, is single use, disposable. A bit extra cost compared to the CPAP device, the ventilator. Then you might use a very simple face mask, which is disposable, reusable as well. But then if you have the constraint in ICU beds and ventilator, and you want to use the patient in the high dependency on the ward setting, then high flow nasal cannula is good. In mild, moderately sick patients. So that judgment is very important, which patients will be on the high flow nasal cannula.
Actually, this is also a very good point. Nowadays, every center is trying to procure high flow nasal cannula, because in Bangladesh, actually, it is reasonably new technology. So whatever new thing comes, people first try to grab that thing, and we are also trying to grab a high flow nasal cannula, and thinking that it is the answer of all problem and it will solve all our problems. But we should know appropriate use of this thing, and at the same time is a relative indication and contraindication, and how to win this thing that can help us to proper use. Thank you, Sami, for your time and your expertise and expert opinions. It's nice meeting you after quite a long period of time. In future, we can meet again with some new other problems. And if I if I can accumulate some other few questions. So, okay, thank you. Hope to meet you
nice
again.
Talking with you. It was an honor with you, and see you again. Okay.
Yeah.
Thank you very much.
Thank you.
If you find this video beneficial, please give a thumbs up, and if you haven't done earlier, to get notification of next video, subscribe the channel and click on the bell icon. Thank you all.